All right, good afternoon, everyone. Welcome to June office hours for AHI. Want to first thank you all for joining us today. Happy June, happy end of June, actually. Just wanted to see if everybody could hear me and if you can see the slide deck. If you could just confirm, that'd be great. Folks hear me?
Can
Yes.
see it.
Hear and
Yes,
see.
it
All
looks
right,
good.
we can hear and see. That's awesome. Good. And the chat, folks can see the chat as well. So we're
Yes.
rocking. Good. All right. So as always, we're recording. So this will be available on our website in the near future for folks if they want to reference back, or for those who are not able to attend today, they can also use this as a reference for information. If you have questions along the way, feel free to jump in, ask, or use the chat function. And we're more than happy to stop and talk along the way. But we'll get going here. We got some folks still popping on, but we'll get going and jump into the agenda. We're going to do our normal policy and procedure updates as we normally do, getting into the policies that have come forth since we last met. Children's updates, NetSmart, quality management performance items. We have MAP billing code alerts that we'll talk about as well. Network training that's going to come forth. And then just some discussion around office hours, materials, dissemination, and information around that. And we'll start off with our policy and procedure information. Jess, did you want to take it away?
Hello. Today we have just a couple of policies that have been updated. We're going to review the children's waiver policy changes, any changes to continuity of care, the palliative care in counseling policy, and the transfer process for children's waiver and OPWDD waiver. Also upcoming, so next month we'll be reviewing assignments and referrals, the comprehensive assessment, interpreter services, and then we do have an update to the eligibility and appropriateness criteria policy. So updates to the children's waiver policy. I just wanted to make sure that everyone knows that it is the health home care manager's responsibility to make sure that they are collecting and maintaining a current attestation for SED for youth enrolled. This is not just the population that is in the waiver. This is for any kid we have enrolled in health home that is enrolled under a single qualifying condition of serious emotional disturbance. You have to have an attestation within the last 12 months stating that they do have the SED diagnosis. So that's the diagnosis plus the limitations. The copy of that attestation form is in our eligibility policy. Also, another thing that has been updated in the waiver policy is that anybody who is being considered for waiver, they have to have that LPHA signed. The LPHA who is signing that LPHA form, they have to be serving that youth. So that youth has to be under their care, and it has to be in the capacity of whatever target population they're going in. So here I put within the SED capacity because that's the majority of the people we have enrolled. So that provider, that LPHA who is signing that form, has to be the treating provider to that member to have that LPHA form signed. So you cannot have a miscellaneous provider that is not serving that member sign that LPHA form. And another update to this policy is going to be for our Med-F youth. It's a very small population of ours, but our Med-F youth has to have an annual level of care. And at the annual level of care, you do have to have that SSI certification. Right now, to get into the waiver for the target populations, you can use those 3 forms, but you can only use those 3 forms for the initial determination. Once they have been made eligible for HCBS waiver under Med-F, it is then the care manager's responsibility to help support the family in getting that SSI certification for that youth in order to requalify for the Med-F target population. Does anybody have any questions on any of that? Okay, next slide. Continuity of care, so our diligent search policy, the biggest reminder here, the only update to this policy was one, that it was annual, and two, that if you have a member who is moving in and out of a pended status, so this could be diligent search, it could be pended due to excluded setting. Anytime you have a member that moves in and out of that status, you have to remember to go in and redo the eligibility screening assessment that is in NetSmart on the bottom left-hand corner. There's one for adults and there's one for children. Every time a member moves in and out of this setting or that status in NetSmart, you have to remember to go in and update their eligibility screening tool. There is a report in DataDen that will help you track those members that move in, that change statuses, to remind you that you need to go in and update that screening tool, and Taylor will touch on that later in the deck. Does anybody have any questions on that? Okay. For our palliative care policy, so counseling and support services, there was no changes to this. It was purely just an annual review. The one thing I will remind everybody is that if these are services you are going to be putting in the plan of care, they have to be placed in the plan of care before that member passes on. It has to be in there, it has to be planful. So this is a proactive piece to using these services. So if you are working with a Med F youth or a youth that is terminally ill, these services do have to be placed in the plan of care prior to that child passing on. Does anybody have any questions on this? Okay, next. The transfer process between children's waiver and OPWDD waiver, that policy remains the same. The process remains exactly the same. That is all laid out in this policy. So as you go to do that, if that is something that you are doing, you would just follow the steps that are in this policy. It happens pretty rarely that we're transferring between waivers, but it can occur. So there's no update to this policy. This would be more of a policy that you would reference as you go to do something. So with this policy or any policies that we have, if you have any questions at any time, you can feel free to reach out. Does anybody have any questions on any of those policies or any other policy questions that they want to bring up? All right, well, if you think of anything, you can email me and I can try to get you an answer. Go to the next slide, Travis. All right, moving on to children's updates. I do have quite a bit of updates. There are things that I want to keep you looped in on. Nothing is truly set in stone yet, so these are just things that are forthcoming. So if you do have questions on any of this, I will try to answer it to the best of my ability. We have received a new policy. It's the core services and billing policy for children. So it's going to be a completely new policy for children, and the effective date on that is going to be for November 1st. So the policy is not even in effect yet, and I've already received the second version of this policy. So needless to say, I have not started the AHI's version of this policy, but I did just want to walk through a couple of changes that we're going to see for children's billing. They are, as you can see here, you're going to get these slides so you can kind of walk through this because this does have a lot of information on it, so you can review later and then reach out to me with any questions that you do have. But we are going to be billing off of acuity level, just like we were before. So we had acuities and complexity. We're going to be billing off of that level moving forward, just like we have before. However, it's going to get much more complex and complicated on the back end. So AHI and NetSmart are working together on a new children's billing questionnaire that will be effective for 11/1. They're going to build it out, NetSmart that is, and they're actually going to try to pilot it out prior to 11/1 with a couple of CMAs, or I'm sorry, a couple of health homes, and then work out any issues that they're seeing and then roll it out to the rest of the health homes in New York State. So for our low acuity members, formerly low, now the complexity is low and standard, we're going to be looking for 2 completed core services per month. And at least 1 per quarter must be face-to-face. And you're going to be required to have an annual interdisciplinary team meeting. That's basically the same that we have now. However, those interdisciplinary team meetings, multidisciplinary team meetings will all be related to billing. So if you do not have that in your record that you had that multidisciplinary team meeting, the interdisciplinary team meeting, you will not be able to bill for services. You're going to continue to do in-person visits for your assessments. And then if the member or caregiver requests that your in-person visit be telehealth, they can waive their in-person visit for telehealth. Moving on to our formerly medium acuity, now we have the early development and intense complexity. We're going to be looking for 2 core services per month. At least one of those must be a contact with the member. And for these folks, you're going to be required to have an interdisciplinary team meeting every 6 months. So right now it's annual for this population. It will be moving to every 6 months. So at least annual or at least 1 in-person visit has to be done when you're conducting assessments. So as you walk through your assessments, just like you do now, you can do them over the course of many days. At least one of them has to be face-to-face. So during the first 3 months of your enrollment, at least 1 member contact per month has to be in person. After that, they're going to have the ability to waive that in-person contact and request to do it via telehealth. So there's going to be this whole process where you would waive that in-person visit and move to telehealth. If the member that you're working with is medically fragile, and that's only 1 member in our entire health home right now, you are going to be able to waive those in-person contacts for a much longer period of time. You can go to the next slide, Travis. Moving on to our formerly high acuity, which is now our complexity, you're going to be required to have 3 core services per month, and at least 2 of the 3 must be contacts with the member. And then you're now going to have a quarterly interdisciplinary team meeting. So this is a big change from annual to now quarterly. And then obviously still you're going to stick with that in-person visits when doing the assessments. And then one of the 2 member contacts can be waived to telehealth at the member's request. Again, additional accommodations for those that are involved in that medically fragile waiver. Then you can see on the bottom here, we go into high fidelity RAP. Right now, we only have 1 CMA in our network that is conducting high fidelity RAP. This will be the billing requirements for high fidelity RAP once 11-1 hits. So we have a lot of changes here as far as core services per month, face-to-face requirements, when those can be waived, when they cannot be waived. Also the addition that we cannot bill without the interdisciplinary team meeting. Once this gets moving and we talk more with NetSmart, and I know in the back end how this is going to work, we will be updating our policy. Like I said, you'll get these slides so you can look into this. And if you have any questions, you can reach out to me and I will answer them to the best of my ability. Like I said, I have already seen 2 versions of this policy and I just received it about 30 days ago. So does anybody have any questions now that they would like to ask?
Yes, I have a question. I'm sorry.
That's okay.
So we have actually come upon a situation where we had a member, only providers at the time are primary care and behavioral health. And behavioral health had a clinical provider as well as med management provider, both of which absolutely refused and was very, very blatant and told us that they refused to attend the multidisciplinary team meeting. So what are we going to do in an event like that, especially when our billing is dependent on that?
That is a great question. So what you're going to do is you're going to do the same thing as you are doing now. You're going to send out that invitation letter and feedback form that's going to, invite them or give them a call-in number that they can call in to participate to. They don't want to do any of that. They can submit the feedback form. They refuse to do any of that and participate. You're just going to fill out your team meeting form in NetSmart, check the box that you sent out the invitation and feedback form, document that they did not respond or they refused to participate. At bare minimum, the team meeting form is the interdisciplinary team meeting at the very basic is the member, the caregiver, or whomever is signing off on the medical consenter. Let's put it that way.
Okay.
So member, caregiver, and then the health home care manager. So as long as you have those three people there, you can bill for that interdisciplinary team meeting. That would back up your billing.
So I'm just going to repeat that to make sure I understood. As long as we have the member, the caregiver, and the care manager, we're okay?
Yes.
Okay, thank you.
Does anybody have any other questions on this? All right, well, if you think of any, please email me and I will try to get an answer to you based off of what I have digested from this policy. All right, you can go to the next slide, Travis. Again, just several slides of updates. Again, to hone in on the interdisciplinary team meeting form, please be using the form in NetSmart. I know we have not updated our policy to make it required. We are working with NetSmart on a new CBQ. We are not sure how the interdisciplinary team meetings will be checked on the back end, if at all, for billing to move forward. So it's super important that we are using that form because anything recorded in NetSmart we can report on. So please make sure that we are using those forms. Next, I just want to jump over to the IRAMS referral portal and staff compliance. I've sent out a bunch of emails about IRAMS. One, just to make sure that everyone's tracking their children's staff. So anybody who works in children's health home, their trainings have to be tracked in IRAMS under the staff compliance tracker. This could be done by your HR department. It could be a supervisor. It's just someone in there has to be tracking the trainings for your staff. It is required, and those have to be kept up to date. So as staff leave, remove, as you get new staff hired, go ahead and add them. And the other thing is, if you are having issues with IRAMS, I know that there are a lot of issues out there with user roles. Please contact the HCS help desk. They'll probably refer you to DOH. So they'll probably refer you out. Just follow up with that. I know a couple of you have reached out to me and we're doing our best to help people, but full transparency, we are also having our own access issues internally that still have not been sorted out. So if you are having any issues, feel free to loop us in, but do reach out to that help desk. And then last week, I did send out the HCBS wait list to everybody. So anybody who has a current HCBS member with referrals, those have to be re-entered into IRAMS. So you basically have to re-refer the member for those services. And then any new referrals for HCBS do have to be entered into the IRAMS referral portal as of 6/17. No one should be accepting a paper referral for HCBS. Does anybody have any questions on anything on this slide? Okay, you can go to the next slide, Travis. I just wanted to put it out there that the CANS Institute has reached out to me to see if anybody in our network was interested in trainings with the CANS Institute. If you are, please feel free to email me and then the topic that you would like them to cover, and I can link you up with them. If it's something that I think the whole network can benefit from, we can do it that way. So I just wanted to put this out there because it was offered to us. So if you guys have any interest in this or at your CMA level or anything you think that the CANS Institute may be able to help with, please email me and then with your topic of interest, and I can see if we can get a training for that topic. Another thing I wanted to put on everybody's radar is high fidelity wrap. Like I said, we only have one. We had more than one CMA participating in this, but now we only have one. Just because it was a pilot program, it still sits as a pilot program. But as of 1/1 of this year, high fidelity wrap did actually roll in under Health Home. So it's kind of the Health Home Plus for children, if you want to think about it that way. We have not been billing for high fidelity wrap. You've just been billing out your regular Health Home rate. And then on top of that, OMH is doing the rest of the piece for the reimbursement rate because it is a much higher rate than the high acuity children. But as of 11/1/2024, to coincide with those CBQ changes, the Health Home will be billing for high fidelity wrap. So those HMLs will be billed out through Health Home. So when you see those new CBQs on 11/1, you'll start to see language around high fidelity wrap. I don't know why that says screening tent. Screening will be added to the cans to flag members who could potentially be high fidelity wrap. So we don't have a date on that, but as you go to do your cans and as this population expands, we will have a component in the cans that you're doing now that will flag people who do have the ability to transition into that high fidelity wrap program. So more to come on that. I'll give everyone a heads up when that's going to be out there. And currently right now they're just rolling high fidelity wrap into Health Home. So they've kind of paused on the expansion of CMAs, but early 2025, they do want to start expanding the CMAs who can serve high fidelity wrap. Does anybody have any questions on this slide? All right, you can go to the next slide, Travis.
It all makes my head hurt.
Lori, you have no idea.
Yeah,
have no
I'm
idea.
like, I'm too old for this. I am too old.
We went from not having a lot of updates in May because things were pending to an overabundance of stuff for this month.
It's like people sit back and are just like bored or something and like just have to keep, I don't know. I'm going to keep my negativity to myself.
Lori, it's fine. You're not alone. It's okay. Taylor's clapping. We feel the same way. Just putting the information out there. My hope is that not all this drops at the same time. That's all I ask. They could not do that to us.
Oh, it'll make you wonder if anybody's going to be left standing. You know what I mean?
It really truly does.
Okay. Drinks, anyone? Next time you have something like this, Jess, you could send out drinks to the network ahead of time.
Lori, where are my drinks?
Schedule it at
You act
5.
like these are my ideas.
Yeah,
I just don't kill the messenger. Don't kill the
I'm
messenger.
not. All right. I'll go back to my
I'll reel her in, don't worry.
muteness instead of mutiny.
Who
I
sent
still
the
have
bush
one more slide
lattes
to
there?
go.
Someone sent bush latte over to chat.
It was me. It's not my preference,
Yeah.
but I'll take what I can get.
Yeah, facts. All right, here's one last slide. I think this is the last
boy.
slide. All right, so I do have kind of good news, guys. On a good news front is you might be getting some money. DOH has finally recognized that maybe with the CANS 2.0 that maybe the algorithm isn't great. So they revamped the CANs. Some people were coming in at a lower acuity or complexity than they should have been. So DOH has really been looking at particularly the Med F population and seeing how the CANs really relates to that population, if it's really scoring them appropriately. But they did look at some examples for other youth, and they have found that there may be some flaws in the algorithm. So what they're looking to do is potentially a CANS 2.1. It's not going to be anything that you guys really need to worry about. It'll be some slight adjustments to the CANs. It's not going to be anything crazy. But what will happen is they're going to look at rerunning anybody who was assessed from 11/1/2023 on and seeing if they run them under the old algorithm, do they come out at the same complexity? And if they come out under the old algorithm in higher acuity, because back then we called it acuity, you may be refunded the rate difference. So you may be looking at a kid who was high, then under the new algorithm got dropped to a medium. So you've been losing about $300 a month for that youth over, for the last 6 months. They may look at refunding that money. They did come to each health home and ask us how they would like our money refunded if we went through that whole process. So I spoke to our finance team. They gave us their feedback. All it is suggestions back. It doesn't mean this is how it will be done. But we might be looking at some refunded money. As I am made aware of that, I will let everybody know. And then on the other front of monies that could be coming to us, anybody who has completed a level of care for children for HCBS on time. So if your level of care was late, it doesn't count. But if you completed a level of care on time, in an initial or an annual, even if the kid came out ineligible for HCBS waiver, there is a payment of $200. So they are looking to go back 2 years on this. So we are waiting to get a list from DOH for youth who are eligible for these payments. So once we have that list, we'll work with our finance department to get that money out. I have not seen that list. They've been talking about it for a long time, but they have said that those lists now are going to be sent out soon. So on this slide, I'm trying to give back everybody money, so at least that's a positive. However, I don't have any definitive timelines on when you will see those quote unquote refunds. Does anybody have any questions on this?
Sound like a politician on that one.
Well, I was taking heat there for a second. I had to give them some good news. All right. Well, if anybody has any questions on all of this, please feel free to reach out to me. You can email me, call me, text me. I'm not shy. I've got a lot of opinions on everything. I freely share them.
Hey, this is Jessica Casey. I just had a quick question about tracking the interdisciplinary team meetings for the health home serving kids. Is there just a thought? Is there any way that we can possibly get this into data then? So from a high level perspective, we can kind of track where we're at and make sure we're dotting all our I's and crossing all our T's, and especially like if I have a care manager that's out and somebody else has got to come in and cover. Is that something that's potentially possible?
Yes, we can build reports in DataDen. So anything that's in NetSmart, that's why one of the reasons we moved it to where we did, so we can accurately track it. We can build a report off of that. Either way, we're probably going to need that report. I don't know if it's just going to be checking a box in an attestation that these meetings are occurring at the required frequency, or if there will actually be a back end look to make sure that they're there, and then you get an error, or the CBQ will go through and only through auditing will we realize that the requirements weren't met. That stuff is completely unanswered. As we work through all of the reports needed for everyone's favorite CES tool, as we get those reports ironed out, we can definitely add this to the list. I'm only hesitant to do that is if the plan with NetSmart is to move everybody to a standardized interdisciplinary team meeting form. I don't want to build a report if the form is only going to move in NetSmart. So once we know more on that, we will build reports to back that up.
Awesome, thank you.
Of course. All right, Travis, next slide.
Thought you were done.
I thought it was done too. Dang.
It never
Okay.
ends.
It never truly never ends. Just an FYI, as you guys go to your children's SPOA meetings, it may come up that SPOAs are going to start completing a level of cares for children for HCBS waiver. OMH is looking to have SPOA do that for members who are coming to SPOA from an excluded setting, or potentially newly referred members going through the SPOA process. So they're going to be completing the level of care is similar to how CS does them for kids who already have Medicaid. So if they already have Medicaid, SPOA could be handling that process. If they don't, they're going to still send them to CS. The transfer process from SPOA to Health Home to the CMA, we have really advocated with OMH and DOH that needs to go through the Health Home, because anybody on this call who has accepted a referral from CS knows that it has to be gone over with a fine tooth comb before you do anything with it. And the only way to ensure that we're getting accurate information that we're then held accountable for is if I look at it. So our recommendation back to them is to not have SPOA refer these youth directly to CMAs, but to go through the Health Home. One would think that would be pretty easy fight and we would get what we ask for. It's not the case. So more to come on this. I don't know a start date for this, but it did come up recently on a children's meeting as we kind of worked through the draft guidance document. I do believe they're hoping to finalize this soon though. And then yesterday there was the modifications and technology request for HCBS waiver youth. That was yesterday. We don't currently have anybody going through this process. If you ever do have someone go through this process or need a modification or technology request, reach out to me. There is a new process for it. I will be updating policy once I have an updated policy. I have an email, but no actual policy yet. So more to come on that. I just wanted to let everybody know. All right, now I think I'm done. Now I'm done. So someone's got to take the wheel.
It's me. I'm taking
Thank
the
you,
wheel.
Jess. Any questions for Jess
Thank you,
before
Jesus.
Anna drives away? No? Thank you, Jess.
All right. Hi, everybody. So the NetSmart demographics section, there's a new required field. So when you're in there editing the demographics page, you're going to want to make sure that you're also choosing sexual orientation for your members. So please make sure you're going into each record and updating this required field as you're conducting your monthly care management activities. So it's similar to all of the other drop downs. You're just going to choose which one best fits your members' orientation. Any questions on that? Taylor.
It's me. All right, Jessica got to torture everybody that serves children, so now I'll torture everybody else with some updates to the CES workflow. Hopefully they're good updates though, and it will make everybody happy, and I'll share some updates to reports. So hopefully it'll be a little bit less painful than those children's updates. So as far as the CES tool goes, previously we had given guidance requiring the CES tool for all of the adult population that had been enrolled for 12 months or longer. We have changed our guidance now. It's not in policy yet, but we are working on editing that, and then we'll get that out to the network. But we are no longer requiring the CES tool for the specialty populations of Health Home Plus AOT, Health Home Plus Step Down, or the OMH Health Home Plus eligible. So if you've done one already, it's not a big deal at all, but moving forward, you do not have to do them for these specialty populations unless you want to for your internal tracking purposes. On a broader scale to help us track this, because we're not having you guys do it anymore, there are some tools and kind of initiatives that we're going to put into place to best help everybody track it and to help us on the quality and compliance side ensure that they're all done timely. The first thing is to make sure that everybody has the appropriate sub-programs. I know I've been harping on this, I think, since DataDen came to fruition a couple of years ago, but it still is something that we audit, and it's something that we catch on audits, not super frequently, but enough to make a point of it, just making sure that you guys have those sub-programs in there, especially, you know, with these changes to the CES workflow. We want to ensure that we're sending out appropriate data to you guys and letting you know when certain people are due based on what population they're in. The next thing for sub-programs is to not add future end dates to your programs. So this is something that I've seen several CMAs do. Not everybody does it, but just something I want to touch on, and I'll share a report with you guys later on in the deck to help kind of amend any of these. But the way that the logic works in DataDen, and this is true for all reports, any program that has an end date in there, be it 2 weeks ago or a year in the future, that program is not going to populate for your member if it has an end date. So essentially the logic is looking for an open-ended program. So you have an end date in there at all, regardless of if it's in the future, it's not going to pull the appropriate program. So make sure when you're putting in your programs for folks like Health Home Plus, for example, you're not putting in like an end date that's a year from the start of the Health Home Plus program. Hannah will jump into kind of how we track that stuff internally on the next couple of slides. But just so you guys know, the programs aren't going to pull appropriately if you do add those future end dates in there. Like I said, in a couple of slides, Hannah's going to touch on utilizing tasks. In NetSmart, that is what we do internally to track these programs and what we've been doing to track the Health Home Plus step-down members and knowing when they're coming due for their CES tool. So she'll jump into that in a couple minutes. The next bigger change that we're making is for the step-down program. So right now we had you guys putting in your your Health Home Plus step-down program for 6 months. And that was, in line with your billing. You guys are still going to do your billing and all of that remains the same for your HMLs, for your Health Home Plus step down folks. You're going to do that for 6 months. But the change that we're making is that we're going to have you keep that step down program on that client's chart for 12 months. Again, not future end dating it, but you're going to utilize either tasks or other tracking tools to let you know when to end that program. And what this is going to do is help us coincide that step down end with when their CES tool is due, because your members are going to be due for their CES tool 1 year after that step down start date. So having that program in there for a year is going to help us track the CES dates for that step down program. And that's something we've been struggling a lot with internally on how to best track it. There's so many moving parts. We came up with that as the best solution. So I will show you guys a report in a few slides that'll help you guys rectify anybody that has had, an end date to their step down program in the past 6 months and you need to extend it just for ease of getting everything cleaned up. But that's how we're going to move forward with tracking that Health Home Plus step down population when their CES tools are due. And again, you guys can choose to utilize the CES tool for these specialty populations if you want to. There's no harm in doing it. You're more than welcome to. We're just not going to require you per policy to do it for these populations anymore. Does anybody have any questions on that? Hopefully that comes as a good some good news for you guys. Travis, you can go to the next slide. I think Hannah is going to jump into how we internally utilize tasks. That way you guys can see how we do this and hopefully incorporate it into your workflow for tracking your step down programs.
All right, so like Taylor said, the step down program, the billing is still for 6 months, but we're recommending keeping the Health Home Plus step down program in there for 12 months so that it helps track when their CES tools due after the completion of the step down, because the CES tool needs to be completed 6 months after the step down program ends or a year from when the step down program starts. So the task feature in NetSmart is actually really simple to use. So you can see right where the red circle is, you click new task. This is on each main page for your members. So you click new task, it'll bring you to step 2. This is where you'll put the task name and description. So as you can see, I put in to remind myself to end the Health Home Plus step down program and complete the CES tool. So this specific member went into step down on June 20th of 2024, and I'm putting the due date a year later, which is June 20th, 2025. So on June 20th, 2025, I will have a reminder to go in and to take out this member's step down program to put in the end date and also complete their CES tool. You can go to the next slide. And then when you log into NetSmart and you click the members page after you have entered this task, every time you're in the person's main demographic page or the main page that you click on, you'll see the due date, 6/20/25, the task name and description, and then who created it, which was myself. And this you'll see right above the problems list on the main page of each member. So it really pops up right in front of you. It's hard to miss it. It's a really great tool to use just to continue to remind yourself. You really can use it for anything, but we found that this is really great for this specific issue that we were working on. Next page or next slide. And then your dashboard. So right when you log into NetSmart, you'll see that I have all of the tasks that I have entered and their due dates, and they're in chronological order. So as you can see, I also use it for Health Home Plus eligibility. So I remind myself to gather additional Health Home Plus eligibility after a year that the person is Health Home Plus eligible in the program. And it's a great reminder. It's right in my face when I log in, so I can't really ignore it. And then you can also see that I've used Step Down Program Over. So this was before we included the SES tool, but from now on, I'll be putting Step Down Program Over and To Do SES tool. So it's pretty simple to use. I don't know if people have used it already. I know that the children's team internally uses it as well, and they find it really useful. Yeah, it's great. Does anybody have any questions?
Yeah, this is Jared from Glens Falls Hospital. I've been using the Step Down program since pretty much day one of this health home. And I've always interpreted it as it's a 12-month period. Well, initially it was a 6-month period, but it was a 12-month period to get the person ready for discharge. So I'm questioning the need for a CES tool at the end of that 12 months when the whole purpose of the 12 months was to prepare them for discharge. And then at the end of that 12 months, 99% of the time, I've actually found them ready for discharge and then just discharged them, because that was the whole point of the step down. So, and I actually track it on my own spreadsheet, so I don't see the need for the use of these other 3 tools that you're pointing out.
So yes, I mean, that's great if the person is ready for discharge, but if that's not going to be the case, then we still need to be doing that SES tool 12 months after they go into step down. So if the step down is ending after 6 months that they're in it, that's when it ends. That's when you're no longer in step down. Sometimes you drop down to a 1-point client, a 1-point acuity. If they're in it if they're in the program for another 6 months, they're going to be due for a SES tool.
Okay, because it was my understanding that a while ago, the step down period was extended to a year.
No, there could have been some confusion because the SES tool is a year after step down. I don't know if that was the confusion.
This was well before the SES tool came into being.
Oh, no. So step down is for 6 months. So if someone's in Health Home Plus, they're in Health Home Plus for a year. Say it's because they're homeless, they become housed. The year comes up that you need to see if they're still eligible for Health Home Plus. They're not at that point. That's when you're going to put them into step down. That goes into effect for 6 months. If they're still doing well after that 6 months, they're not needing to be bumped back up to Health Home Plus, then the program's completely gone. They can still remain in the program if they're eligible and qualified, and there's still things to work on. But if another 6 months goes by, you need to do the SES tool. And Jessica, you can correct me if I'm saying anything incorrect.
Yes, you are correct. I was going to jump in, but I didn't want to interrupt you because you were on a roll. Yeah, so Health Home Plus step down has always been 6 months. It still truly is only 6 months because you're getting that medium billing rate for those 6 months guaranteed post Health Home Plus, regardless of how you answer those questions on the HML. So if you have a member who's enrolled in Health Home Plus for 12 months, you get that high acuity rate, that highest rate. Then it guarantees that medium rate for the next 6 months, as long as you answer the questions appropriately in the HML and you keep them on Health Home Plus step down. The reason we're asking that program stay in there another 6 months, so now 12 full months, 6 months of billing, 12 months of the program, is so we can better track the due dates for the CES tools. If you have a different process internally that you're going to use to track your Health Home Plus population and your Health Home Plus step down population, you do not have to use the task function. We just use.
Yeah, the only thing I'm concerned about is, I guess I'm gonna have to look back because I distinctly remember hearing that it was extended to 12 months. And that I asked the question just to make sure that I knew that it was extended for 12 months. Because of the acuity of the clients that we work with, and the fact of the matter is that at some point 6 months isn't enough time to help a person who's chronically homeless maintain that after only 6 months of being housed. And other qualified conditions, of course, but that's just one example. So.
Yeah, if you have anything stating otherwise, please forward it along, because it's always been 6 months. Now, if someone can end their 12 months in Health Home Plus and still requalify for another 12 months in Health Home Plus.
Oh, yeah,
that's
I'm
still-
well aware of that, yeah.
Oh, okay. I didn't know if we were, yeah, if you have anything else stating the contrary, please let us know, because that means that there is guidance that is out there that is inaccurate. So if you find that and you come across that, please forward that to the Health Home.
All right, thank you, Hannah. Yeah, anybody that has their own internal tracking, you don't necessarily need to use the tasks. We just wanted to present it as an option. That's worked really well for our internal team, because it is right there in NetSmart when you log in as a nice reminder, and it's not on a separate document that you have to update and keep track of. You just put it in there once and you're all good to go. But by all means, if you have established ways to track this kind of thing already, feel free to use those. We do ask, however, that you do put that step down program in for the 12 months, because it is going to make the reports that I'm going to jump into the most accurate and the most reliable. So I think, Travis, you can go to the next slide.
Hey, this is Jared again. I'm sorry. One more question. When you bill for somebody in the 12, you say they're in the program for 6 months as a step down. Does that mean that
Yes.
they bill at the high level or at the low level?
There, you would get the medium rate for that
The
member. if
medium
you're
rate.
billing
Okay.
step down.
Okay. All right. That was my question. That was the understanding that I had. That's what I meant by billing for 12 months at the medium rate as opposed to the low rate. So, all right, that was a little bit of confusion on my part. So it's cleared up with me. Thank you very much.
Yeah, so yeah, thanks, Jared, for bringing that up. Yes, for Health Home Plus, you get the Health Home Plus high rate as long as they remain Health Home Plus. Once they lose their Health Home Plus eligibility, because let's say they're housed or they haven't had any inpatient visits, they then go to step down billing. So that's that medium rate. That's that guaranteed medium rate. After that, the member could still be at a medium rate.
I'm
with the
sorry to interrupt.
HMO
And that medium rate is for the period of 12 months of the step down.
for 6 months. It's only
Oh,
6
only for
months.
6 months of the step down.
Yes. But that member could still be billed at the medium rate after those 6 months, depending on the answers to the HML. That step down period guarantees the medium rate when that member could potentially be lower. It makes sure that you get that medium rate. Then after that, that person could go lower or they could maintain that medium rate code. It all depends on if that member is HARP. And it also depends the answers to that HML, how you answer those questions.
Okay, like the HML, like were they homeless within the last year?
Yeah,
And
so
then
anything,
how were they housed within the last year?
Right, so if they weren't, if the
Okay.
homelessness piece would still, that would still make them Health Home Plus, but if they had like,
Okay, so the step
one
down
Hospital
ends after
stay,
6 months.
arrested.
Okay, all right, I get
yeah,
it.
not enough to kind of tick them back to keep staying Health Home Plus, but enough for you to keep billing at that medium rate.
Okay, all right, I get it now. Thank you very much.
You're welcome.
Thanks, Jess. Okay, jumping back into the changes to the workflow. So the CES tool for pended members, hopefully this will come as good news for you guys. We have some good additions to the reports. So for members that have gone into a pended status, DSE or excluded setting, and then come back into enrolled, their CES date is pushed out and it will be due 365 days from the first of the month in which the member re-engaged. So an example down below, if they enter DSE, but they're found and they re-engage on 6/20 of 2024, the member's CES tool is due 6/1 of 2025. If you want to go to the next slide, Travis, I'll kind of talk about, I know that seems very daunting to track all of that, but we've incorporated it into the reports. So I'll just touch on the changes to these reports and then show you guys some screen grabs. So the two CES tool reports that you have had available to you in DataDen, they will get an update with the refresh tonight, and you will have new data in there as of either later today or tomorrow morning at the latest. So the first report being the CES submission report. So that is going to be the report that shows you all enrolled members that have had a CES tool completed before. It has previously and still calculates the next CES action due date based on the recommendation. So in there, it will show you if you've completed the CES tool and they got a recommendation of continued services, it'll give you a date that's 6 months or 180 days, sorry, from the date that you completed that CES tool. That remains the same. The new addition to the report is that it will now have members that have returned from a penned status, their CES date will override the recommendation date. So say you've done a CES tool for a member and you got recommend continued services, and then that member went into DSE and came back, the new date will override the date that was previously populated when you had gotten the recommendation of continued services. So we'll show that on the next page, just a couple more points to touch on. You'll see this on the next page as well with the screenshot. Those members that have returned from a pen status will be highlighted for you in blue just for ease of tracking purposes and to make sure that all of your dates are aligning appropriately. CES tools, we found this out from DOH last week. CES tools are due to the date listed, not the month listed. So the dates are now available in DataDen, or they will be with this refresh. Billing cannot occur if the CES tool is late and the billable service is delivered after the due date. So important to keep that in mind. And then as far as members that get recommended discharge as their recommendation, the discharge needs to be completed on the date listed. So again, to the date, not the end of the month. And the DOH 5235, if you're issuing that, will need to be mailed out prior to that date, and no billable core services can be delivered after that date. I know that's a lot of a lot of things. Does anybody have any questions on that?
Yes, I do. I just want to make sure that I've got this right. So we do no longer complete a CES tool after they come back out of DSE?
Nope, you're going to do your eligibility screening or your initial appropriateness. You'll do that, but you're not going to have to do the CES tool until 1 year after they return from DSE.
Okay, thanks, Taylor.
You're welcome. Travis, if you want to go to the next slide. So this is just a screen grab of the report. Yours is going to look pretty much the same. This is a non-PHI version, so hence the funny CMA names on the left-hand side. Your guys will also have your client names and their SID numbers, but we're just not having PHI on this one. So you can see the member with the blue highlight and their CES action due field. They originally did their CES tool on 12/8 of 23 and got recommend continued services. but their CES action due date is saying 5/29 of 25. So instead of having that 6 months, it should be just like the one above it. If they weren't pended and came back, it would read 6/8 of 24 that their new CES tool was due. But because I can clearly tell they went in and out of a pen status and came back in on 5/29 of 24, their CES is not due until 5/29 of 25. Does that make sense to everybody? Let me know if you have any questions on that. I forgot to grab it in the screen grab, but there's also a filter at the top of this report where you can filter on just folks that have returned from Pend. So you'll have that option if you just want to look at that specific population, but it will highlight in blue on there for you guys just for like ease of checking your dates to make sure that they're appropriate.
Hi, this is Mary. Can we just clarify that we have to do the CES tool, the actual date that it's due? So the actual date that it's due based on the initial consent date?
Yes.
Right? Okay. So if somebody consented June 1st,
23.
but let's say they consented, June 1st of 23. Now they're going to be, so they consented that date. You do it a year from the date that they enrolled.
It's Saturday.
So now 6/1/24 is a Saturday. So is it
You
gonna?
can do them early.
Yeah, you can do it before. This is brand new guidance. I know this is obviously new and this hasn't been how we've done it in the past, but this has been brand new guidance as of like earlier this week or late last week, straight from DOH. But yes, it is going to be to the day. If it does fall on a Saturday or something like that, you could do it early.
So we could do it earlier, but not later. So
Correct.
in addition to figuring everything else out, we're already figuring now we have to take into account vacations. Right?
And weekends.
I guess that's why we have to continue to complicate this process, but I know it's not on you guys. It's just it's frustrating.
We would be doing it in May.
Oh, we totally get it. We have this
The amount
internal
of
conversation daily
administrative
where we're
burden.
losing our minds trying to come up with the most appropriate guidance and the easiest way to disseminate it to you guys. And we agree, it's overly complicated, to say the
Well, and
least.
I agree with everything Lori's saying, and I'd like to see some of these people that are putting this in place actually get out here and do this job. Very frustrating.
Amen,
It's
sister.
hard to
Preach.
retain staff now.
That'll move the CES tool up a month.
It will move the CES tool up a month.
Maybe have someone
Yeah.
who signs in the first week of a month in order to get it in on time. You might have.
All right, Travis, you can go to the next slide. All right, the next report, the initial CES due. So again, this one has been available to you guys. Same things. The only thing that we've changed is based on some feedback from CMAs. We've changed the report structure so that you'll see members with an enrolled status that have been enrolled for 11 months or longer instead of 12 months. That way it's not springing upon you when you have one due. Again, with this date thing, you'll see it a little bit earlier. You'll see it a month earlier. That way you have it on your radar instead of it just populating on there once they've been enrolled for that 12th month. Again, this is going to be members that have not had a CES dual completed before. And similarly to the other report, it's going to show you members that have returned from a pen status, and their CES date will override the date due based on their consent date. So their new date based on the date that they re-engaged will override the consent date, and those will be highlighted for you guys in blue. Next slide, Travis. Again, just a snippet of this report basically looks exactly the same. You have your consent start date, your initial CES due date, your initial CES month. The only reason that month is there is for filtering purposes. The initial CES due date is based on the consent date. So when you factor in the year that somebody consented, it just gets a little wonky with filtering. So we wanted to provide a quick, easy way for you guys to be able to filter that by month without the year getting discombobulated in there. Once we get through everybody's CES tools in 2024, we may be able to delete that out of there just to make it a little bit cleaner. But for now, if you do want to filter by month, filter by that initial CES month column, and that'll give you all of your CES tools that are due by month. You can see the members in the blue there. The first one had a consent date of 6/7, so technically they would be due for their CES tool in June, but they are now not due until May of next year. So if you look on this and you see a month that is already passed in this year, that means that it is due next year for that month. Again, the dates get a little convoluted because of everybody consented on a different year. But just know if the month has already passed, that means that it's due for that next year on that date. Again, you guys will have the return after pen filter at the top. So you'll be able to click on that and filter to see anybody that has returned from the pen status, all collectively if you desire to do that. Any questions on this one? Okay, and then the new report that is going to be available in there is going to be a sub-program start and end report. So hopefully this will be helpful for you guys as we start to kind of utilize these programs to best know when the CES tools are due. So right now you guys can utilize it when you get in there to make sure that you have no future end dates. Again, if you have future end dates in there, those programs are not going to populate appropriately, and then you're going to have maybe folks populating on your sheet as due for their CES tool, but really they're Health Home Plus, but you had a future end date in there. So this will ensure you can go in there and quickly see all of your members, and you can delete out in NetSmart any future end dates. You'll also be able to go in and check your step down programs. Again, we're going to be setting those for 12 months versus the 6 months that's been in previous guidance. Again, 6 months for the billing as always, but we'll have that program in there for 12 months. That way you guys can track when your CES tools are due. So this program will have any member that has an active sub-program. And as of right now, I made it so you're also seeing sub-programs that have ended since 6/1/23. That way, I just wanted you guys to be able to go back in and see any that have ended potentially for step down or anything like that. So I just gave a pretty broad window for those sub-programs that have ended since 6/1, so you guys can go and check those out. And this will include all sub-programs. So, you know, I primarily built it to help track for the CES tool nonsense, but all of the sub-programs are available on there. So you'll be able to see your HARP, HCBS, things of that nature. So you can make sure that those programs are up to date as well. Next slide, Travis. And this is just a snippet of what it looks like. You'll have one row for each sub-program. So if you have a member that has a whole slew of sub-programs, you may see their name more than once. That's totally normal and expected. You'll run one row for each. It'll show you the sub-program start date and the end date in there. Again, utilize this to go in and make sure you don't have any future end dates on your sub-programs, and check that Health Home Plus step down population to ensure that you have that with no end date. But you want to make sure if you have an end date in there that was from 6 months, but that full year hasn't passed yet, you're going into NetSmart and deleting that end date out. And if you guys have any questions as you're working through this and kind of cleaning up those sub-programs and the population, please feel free to email me and I'm more than happy to help. Next slide.
Taylor, this is Sarah from SLPC. Can I just ask a question quick?
Yeah, absolutely.
Okay, with the change, you know, we had been sort of, probably most of us doing this month to month. So now with it moving forward, it's really due, you know, on the day or, you know, before. Is that something you want us to start implementing as of 7/1? Or do that for June if we have CESs left to do?
If you have CESs left to do, I know it's the end of the month, so there's probably none that are kind of falling in that category. If you do have them, then yes, do them for June, but if not, moving forward for 7/1 is fine.
Okay, thank you.
You're welcome. Next slide, Trav. Okay, so with all of that said, I wanted to give a little poll, and you guys can feel free to shout out or send it in the chat. With not requiring the assess tool for the specialty populations of Health Home Plus Step Down, AOT, and the OMH Health Home Plus eligible. They are still populating on both reports. So they're still populating on the SES submission report, and they're still populating on the initial SES due report. So we wanted to kind of see what the network's preference was on what to do with these populations. So you guys will be tracking them through your internal practices and utilizing tasks if you choose to. But we want to know how you want to see them represented on the reports. So we have a few options. The first of which is that the date can stay the same. So it would be either based on the consent date, or it would be based on the original SES due date if you guys had done a SES for them already. Basically, you would just know internally, and we would know when we're doing QA that we're just not looking at anybody that has one of those sub programs in there. So just kind of omitting them. We can either pull it and omit those people that have the sub programs. It is listed on both of those reports, or just kind of forget that those are there if they have those reports in there, or sorry, those programs in there. Our second option is to leave the due date blank for those populations, or the third option is to remove those populations from the reports altogether. So I'm happy to answer any questions, but if anybody has any strong feelings about how they would like it to be represented on the reports, please feel free to shout out or put it in the chat. We truly didn't know what the best option was, so we wanted to get opinions on what would be the easiest for folks to track.
I
This is
personally
Jared. In my
would like
opinion,
them to
it's
stay.
always,
Sorry.
if it doesn't need to be there, then don't have it there.
Okay. Okay, we've got some things popping up in the chat. Thank you, everybody. And we can move on, but if you have more opinions, feel free to put them in the chat, and then we'll kind of go over everything as a team next week and figure out how to move forward with the reports. Just know for tomorrow, when you guys are looking in there and they're published, the date is the same based on either the consent or the original submission date of the SES. But moving forward, we will do whatever the network preference is.
So far, due date blank is.
Looks like blank due date is the winner so far. You can go to the next slide, Travis. Okay, so status change for the eligibility assessment. So this report has been in DataDen, but I just wanted to touch on it because Jessica talked about it earlier. This was a change made to policy that members do need a new assessment due, and this is for children and adults. They do need one due within 30 days of re-engaging. So when they come back from that pending status, DSE or excluded setting, they do need a new initial appropriateness or eligibility screen, whatever you want to call it, due within 30 days in order to bill. So this is called Status Change EA in DataDen. Again, that's available to you guys. It'll show you the date that your new eligibility screening is due based on the date that the member has re-enrolled. I just wanted to make you guys aware if you didn't know it was there. I did notice going through eligibility screens last month for audit, there were a number of them outstanding, and I'm sure Courtney has emailed you guys to let you know that your billing is not going through if you don't have these done. It is a separate population to track when these folks return from PEND, but this is available for you guys in DataDen under the compliance section. Any questions on this report?
Yeah, can we just confirm that the people that were previously there, I think it was February of 2023, do not need to have the this screening tool?
Yeah, well,
Okay.
yes, yes and no. So the folks that had, the policy went into effect 2/1 of 2024. So if your member had enrolled prior to that, they did not need their initial eligibility screening done in the new form. However, if they go into a PEND status and come back, they'll populate on this report and you will need to do one.
Okay, thank you.
You're welcome. All right, I think that's it for me. Jess, I'll hand it back over to you.
Yeah, I'm back. Um, so great to be here. I just wanted to give a quick update. This is not new information, but I just wanted to go over a couple of things when it comes to specialty populations that we have seen through auditing that we just want to make sure that we clarify. So for Health Home Plus, we want to make sure if we're enrolling someone under Health Home Plus for SMI, they have to have a documented SMI diagnosis. In our eligibility policy under the SMI definition, I do note out all of the codes that would fall under a specific SMI diagnosis. You do have to have one of those specific diagnoses in order to qualify for SMI, and you have to have it documented in the member's record. And it should be the member's primary problem. If they're enrolled in Health Home Plus for SMI and homeless, it is very, very, very important that homelessness is listed as a social health problem so it can be addressed in the plan of care. We see a lot of people who have been enrolled for Health Home Plus and for homelessness. It's not addressed in the plan of care. There's no problem in the problems list. It's not noted on the comp. Ideally, you'll have that golden thread of documentation where it's also noted in the comprehensive assessment that they're not housed. We see a lot of records that don't have the problem, don't have anything in the plan of care. The comp is stating that they're housed, they have a stable place to live. So none of those things aren't meshing well to support that billing at that rate. So you want to make sure if they're Health Home Plus for homelessness, that you have the social health problem, it's being addressed in the plan of care, and that it's noted on the comp. We understand that things change from the time of assessment, so it might not, the comp might not accurately reflect what's going on currently. Just wanted to point out for our clinical discretion, if you are enrolling someone Health Home Plus for clinical discretion, you have to have documentation from the SPOA's clinical discretion or from the managed care company. It cannot just be a SPOA referral that does not make that person Health Home Plus for clinical discretion. You have to have a letter, a form, an email, something from SPOA and or the MCO noting that they agree to put that person Health Home Plus for clinical discretion. Another category that we're seeing some confusion on is that criminal justice involvement. That member has to have an SMI diagnosis and they had to have been released from jail or prison within the last 12 months. And they require reconnection to providers and services in order to avoid reincarceration. The incarceration has to have stemmed from poor connection to mental health treatment, poor management of the SMI condition, which has led to the incarcerations in the last 12 months. That then makes the person eligible for Health Home Plus. So you want to make sure that you have all of that documentation in there to support that billing rate. So if you guys are ever going to identify someone as Health Home Plus, or you get a new referral and you think that they might be Health Home Plus and you want a second opinion, you can always reach out to the health home and we can take a look at the documentation and let you know if it fits the criteria. In these three categories, sometimes there is the ability for some subjectiveness, we'll call it, and we've been finding that there are people enrolling and billing under this high acuity rate for members that are not eligible. Does anybody have any questions on this?
Yeah, this is Jared again from Glens Falls Hospital. I'm commenting on the third one, criminal justice involvement. I've actually had email interactions with the Department of Health, and it's under their impression that if a person's on parole or probation, it also counts as criminal justice involvement, even if they haven't been coming out of incarceration within the last 12 months. And that reason is to help them, prevent them from going back into jail.
Yeah, so in some instances, you can have somebody that is active on parole or probation and you can move them into the Health Home Plus level of billing. You have to have documentation though from probation or the parole.
Oh yeah, we
officer.
certainly do get that.
Okay, perfect. Yes, we have seen in records where people will not provide the name and number of their parole officer, and we have no documentation, and it's almost just self-report. So you have to have documentation in the member's record
Yeah,
from that.
we've
parole.
actually found that the parole officer or the probation officer is more than happy to provide that information because they like the level of support that we provide.
Yes, typically that is absolutely accurate. But there have been records that we have reviewed. Glens Falls Hospital is not one of them. But we have reviewed many records where it's questionable if this was the appropriate billing rate or not. Any other questions on this?
Yeah, the other one I have is, this is Jared again, for the Health Helm Plus and the SMI. We have people that come out on the SIST program, the State Strict Intense Supervision and Treatment of Sex Offenders.
Yes.
These are direct referrals from OMH, and they may not have a SMI that meets the criteria of the list that you've given us. But as it's a referral from OMH, they've asked that we put them in the Health Home Plus population, and we have documentation of that. And they also have the criminal justice involvement.
Yes, this population of people, I have had emails, well, I have sent emails to OMH and DOH on this very specific population because we do believe that they should fall under the Health Home Plus category and not be subject to the CES tool. Unfortunately, I have not received much communication in response to my requests. If you, Jared, have somebody that you can email me and I can communicate directly with them, I'm absolutely happy to escalate the matter to somebody else because this is not the first time that very specific population of people has come up. We do believe.
Yeah, the gentleman's name is Craig Wilson, but he recently stepped down, and this other woman's just stepped back up into the position, this new woman, so I'd have to talk to her. This transition took place literally this week, but
Maybe
he
that's why I
always
don't
sends
see
me a letter every year indicating that that person is in the CIS program and he is from OMH and they do require this level of care.
See if she gives us.
Okay, yeah, if you have any contact information you can send to me, that would be great. I just wrote a note. I'm out of the office for the rest of this week, but it is a population that I can press on again to see if I can get some answers. Typically, I got an email about 3 to 4 different people a couple of different times and basically be a pest, and then eventually someone will respond. But if anyone has any more direct contact information, I know Sarah from SLPC, I know we have talked about this too. If you know of someone I can contact more directly, that would be great. But so far I've been unlucky getting a response from somebody. But yes, I do agree with you, Jared, on that population.
All right, thank you.
I'll send you a few names that I think might be helpful, Jess.
Thank you, Sarah.
You're welcome.
All right, you can go to the next slide. Okay, just a reminder for our HARP folks. If you have a member that is HARP eligible, we are auditing just to make sure that if they're HARP eligible, that you have talked to them about becoming HARP enrolled. They don't have to follow through with the process. That should be noted in the member's record. If they are HARP enrolled, it should absolutely be documented that the health home care manager offered HARP services and/or core services to that member. We are being audited for that. The state is auditing us, the insurance companies. So I just want to put that reminder out there that it should be in the member's record that has happened. Right now, we look for that in notes. We may be looking at noting that somewhere else in the record that makes it reportable. However, that would probably in turn, Lori, correct. There was a form for this. That form no longer exists. We are looking to see if potentially we could add that form. I don't really want to make people add that form though, like have another form to fill out. So there was a spot audit done for one of our MCOs that I worked with our MCO on. We're about to meet with them actually in 10 minutes. And I just wanted to give a shout out to RISE, Champlain Valley Family Center, and HCR. When I audited their records, 100% of their HARP enrolled members had a documented conversation about HARP services and core services. So you guys get gold stars. But just a reminder to please, as you work with your members, please make sure you're noting that. I know sometimes people are very dismissive of HARP, and I know that they don't want the services, but we do have to make sure that we are offering them. So thank you to RISE, Champlain Valley, and HCR for having 100% of their members have a documented conversation. Taylor with the Taylor Swifts. Let's go. Yeah. All right. Hopefully this is the last you hear from me today.
Thank you. All right, so I got this from here on out. Thank you, Jessica, Taylor, and Hannah, going through that wealth of information today. Redesignation. So we are going to be going through our adult redesignation for the month of September 2nd through 30th. State's going to be doing a virtual audit of our adult health home program. And we actually have to respond by July 1st with our preliminary information, policy manual, etc. They'll be sending, hopefully in August, their list of SINs that they're going to be sampling. So we'll know more then what that sample will be. I have here just a snapshot of what the percentage of designation time frame is now that the state has. So you'll see on the color coded on the right, on the bottom, what designation scorings are. So we have an 85% as our threshold for plan of care. I shouldn't say plan of care, for PIP, for our comprehensive chart audits when we do that for our organizations. That's why we have that as our threshold. That's why we have corrective action process start for organizations that fall below the 85%, because you'll see here, if you fall below an 83%, an organization will fall into a 1-year provisional designation status. We don't want a 1-year provisional designation status as a lead health home. We don't want that, and we're not going to have that. So that's why we have an 85 as our minimum standard. As we move forward. I know that's high. I know that's a B. It's a solid B if you're looking at grades. But we want to maintain a solid standard moving forward. So that's why that's there. It's a quite high ratio. It's the way it is now. It's the world we live in. The highest you can get is a 4-year. That's a new category that wasn't there before, 95 to 100. The 1-year provisional is a new category. The 5 is a new category. The 6-month provisional. The D designation is a new category. So a lot's changed in that. You'll see on the top on the right hand side, the domain 3. That's the chart audit across the network. That used to be weighted at 30% when the state came in and audited as your overall score, 30% of your overall designation score. It's now 60%. So 60% of our overall score is going to be chart audits across the network. So hence, again, why we have 85% as our threshold, because 60% of that weight is part of our redesignation score. So just wanted to give folks kind of the why behind that. So I don't know if there's any questions around it. They're coming. They're going to be auditing our adult program. I think we're in good shape. Again, we have a pretty robust quality program. We're out there. We've really done a lot around our quality policy. We've got data den. We've got the quality notebook. We try to do a lot with providing things for the network. You all have been very receptive, which we greatly appreciate, and all the changes we put forth over the last couple of years. So we thank you for that, and all the partners that you've brought forward, and the partnerships that we've created and enhanced. So thank you. So we'll get it. Billing blocks, the next thing I wanted to touch on, they went in effect 6/1. There's 3 things that are touching on it. So this is more information for you guys at this point, but lead health homes across the state have the 3 billing blocks, the initial appropriateness criteria, the CES tool, and the plan of cares. They're all things that you're all doing in the trenches through CMAs, the care managers, the supervisors, that wraps up to the leads having to load those up through MAP. if they're not in MAP on the rolling basis now, can't bill, and that's happening as of 6/1. Well, there's codes that are coming through, so Courtney now gets a code kickback. She's going to start to reach out as another level of support. It's not the final level of support, but another level of support for folks. An example would be for the plan of care. She'll get a warning if there's going to be the last month of billable service for a plan of care that's going to expire. So if you got a couple people on your particular CMA roster that's got a W that's tagged next to their SIN, she's going to let the supervisor know that there's a couple people with a W that's going to be kicking up, that's going to expire in the next coming month. Don't use that as your last resort, though. Use the tools that we've put forth and the tools that you've developed within your organization to be proactive. Don't be reactive. But we will make sure that we let you know when these block warning codes come forward. I'm not going to read through each of these slides because I know you guys have been overwhelmed with all this information today. But I just wanted you to have these slides so that you can have that as reference about what these different codes are. Same thing for the CES tool. There's going to be different codings that are going to come through that Courtney will get for overdue CES that should be in that are not. What those different codes are going to look like that are going to be blocked, that should be submitted, but that are not in the system, etc. So that stuff's all happening. Data Den. Taylor went through a bunch of reports today. A lot of good changes, but there's been a lot of changes with Data Den. There's also been a lot of staff changes over the last couple of years in the network, a lot of supervisory changes in the network. It's time for a refresher. We've updated our non-PHI version of Data Den. We're going to do a network training with a new updated non-PHI version of the Data Den, so stay tuned for that. So that's going to come, and we're going to walk through what that's going to look like, show how all these reports function again, do drill downs, how you can export the different reports, etc. So look forward to that. It's going to be coming up shortly. We'll look at maybe possibly doing more than one training if it's necessary for folks, and give that as an option for people. So I think the timing's good for that, especially given all the stuff with the billing block and the reports around it. Next thing around office hours. Today was a perfect example, a lot of information. I really want to stress to folks, make sure you get this to your staff. Not every organization has all their staff on here. Some supervisors don't want all their staff on. They just want to keep it with their supervisors. Some agencies want all their staff on. We post this on the recording on the website for accessibility for folks to get on, to check it out if they weren't able to be on today. I send the deck out to the folks that are on the distribution list. I just ask that folks get this information out so that they can have it. It's not an all-encompassing distribution list. There is feedback that comes back at times that people have no idea about some of the information that's put out there. Whether that's true or not, I have no idea. But we just want to make sure at the end of the day that information is getting dispersed, that's getting sent out, that policy expectations is getting put forth to the network, and that it's being shared so that people can get the information. And if we need to improve in areas, please let us know. We want to know that too. But I do want to make sure that folks are getting information. So thank you. And I wanted to let folks know we've got 6 organizations you'll see on the bottom right-hand corner that are in various stages of going through the application process. People USA still in the hopper. They're out of Poughkeepsie, New York. They're trying to get finalization to become a provider in Warren County for adults. Open Door is Warren County as well for adults. Unlimited Potential would be adults for Saratoga County. Step by Step would be adults for St. Lawrence County. Changed by Christ would be for Clinton County for adults, and Saratoga Hospital is our newest organization that's going to be starting the process for adults for Saratoga County. So they're all organizations that are looking to become downstream providers in our network, which would all likely come on at the same time with our good fortune, since they're all in the system and bottlenecking at once. They'll probably all come through at once, and we'll be onboarding 6 agencies all at the same time. It's the way it's going to look and the way things have been going. But that's going to be good. There's all kinds of referrals out there. There's never a lack. I don't know if that's good or bad, but there's a lot of people who need assistance, and we're hoping to get these organizations on board to provide some more support out there, and we're looking forward to it. So just want to give folks that input as well. And that is it. I just want to thank everybody for hanging in there with us today. This was a very long office hours. Thank you for all that you do each and every day as usual. And I just wanted to open it up quickly if there's anything anybody want to talk about that we didn't, or anything you wanted to mention.
Actually, I do. This is Christy. Forgive me, I don't want to waste anybody's time if this has already been discussed at a previous meeting maybe that I wasn't part of, but I wasn't aware of a plan of care building block. So I didn't know if that's new information or that's information that's previously been shared. I don't want to waste anybody's time.
Oh, this has been out there for better part of a year. It's been shared on prior office hours,
Okay.
Throughout the network, for quite a long time, Christy. I can talk to you
Okay.
offline if you like.
All right, thank you.
Yes. Any other questions? All right. Well, thanks everybody. We appreciate it. Have a good afternoon. Thanks again. Take care.